The Prevention of Malaria in Pregnancy. Green Top Guideline number 54A, April 2010. Background. Malaria can be life-threatening, but it is preventable. Malaria is caused by the bite of the female Anopheles mosquito, which results in infection of the red blood cell. The species determines the pattern of the disease. The species of the 1,370 imported infections reported in the UK in 2008 were 79.3% Plasmodium falciparum, 12.9% Plasmodium vivax, 5.5% Plasmodium ovale, and 2.1% Plasmodium malariae. By far, the heaviest burden of malaria in travelers from the UK is the Plasmodium falciparum from Africa, mainly West Africa, particularly Nigeria and Ghana. Plasmodium falciparum is the most dangerous species of malaria and causes the vast majority of deaths worldwide. In UK travelers to Asia, particularly to the Indian subcontinent, infection with Plasmodium vivax is more likely, and this can cause a relapsing type of malaria. Plasmodium ovale can also cause relapsing malaria, and Plasmodium malariae is unique, owing to late recrudescence after many years. Other places where UK travelers have acquired malaria include South and Central America, including Great Exuma in the Bahamas, Hispaniola, Oceania, and the Middle East. In the UK, the majority of travelers with imported malaria report visiting friends and relatives in their family's country of origin, especially in West Africa. The uptake of chemoprophylaxis among people residing in the UK who present with malaria in the UK is low. Special effort to tailor malaria prevention messages to migrant groups could reduce the risk of travel-associated malaria significantly. What are the medical complications of malaria in pregnancy? Malaria infection in pregnancy carries significant risk to mother and baby. UK-based residents have low premonition and high susceptibility to malaria infection. Malaria infection in pregnancy may result in reduced birth weight in the fetus, and this may have health consequences in later life. Malaria in pregnancy adversely affects the mother and fetus. Maternal mortality or pregnancy loss from miscarriage, stillbirth, and premature labor are the main complications of malaria in women with low premonition, and complications are likely to be equivalent or worse in women who are not immune. The principal effect of malaria in pregnancy in women from endemic countries is low birth weight, and this could have consequences on health in adulthood. The clinical manifestations in pregnancy depend on premonition, that is, the degree of naturally acquired host immunity to malaria. Premonition depends on repeated exposure to infectious anopheline bites, so UK-based residents will have low or no premonition. Prevention of malaria infection in pregnancy. What advice should pregnant women be given if they are considering travel to a malaria endemic area? Pregnant women should consider the risks of travel to malaria endemic countries and consider postponing their trip unless travel is unavoidable. Table number 1. Summary of the main consequences of malaria in pregnancy in non-immune female UK-based residents with different levels of premonition to malaria. Severity indicated by plus sign when known. If travel is unavoidable, what advice should pregnant women receive about preventing malaria infection? Advise the woman to seek guidance from a center with expertise on malaria risk and avoidance strategies. Advise women that a fever or flu-like illness while traveling or upon returning home up to 1 year or more may indicate malaria and requires medical attention. Advise the woman on the risk of being exposed to malaria at her intended area of travel. The ABCD of malaria prevention is a useful formula to remember the components of malaria prevention. A is for awareness of risk, B is for bite prevention, C is for chemoprophylaxis, and D is for diagnosis and treatment, which must be prompt. Women need to be educated about possible measures and, where possible, provided with written information in their own language. The Department of Health produces Think Malaria leaflets, which are available in 11 different languages and can be obtained from DH publications. What needs to be done to raise pregnant travelers' awareness of the risk of malaria? The risk of malaria is dependent on a variety of factors, including the level of transmission in the area or areas of travel, and the time of year, rainy or dry season, the presence of drug-resistant strains of Plasmodium falciparum or Plasmodium vivax, whether rural or urban sleepovers are planned, length of travel, and the availability and the likelihood of uptake of malaria prevention interventions. For example, if a woman proposes to go to urban tourist areas of Southeast Asia, such as Bangkok and Phuket, and stay in air-conditioned hotels, the risks are considered minimal for malaria, whereas urban travel in sub-Saharan Africa and New Guinea, Papua New Guinea, and Papua constitute a significant risk of infection. For UK residents, the risk remains disproportionately high in the African diaspora of travelers visiting friends and relatives in West Africa, particularly Nigeria, Ghana, and Uganda. The risk of contracting malaria during a 1 month stay without chemoprophylaxis, regardless of country of residence of the traveler, has been estimated from retrospective studies of large numbers of travelers. Table number 2. Risk of contracting malaria during a 1 month stay without chemoprophylaxis. Despite applying effective anti-mosquito measures and good compliance to chemoprophylaxis, women can still contract malaria. Education about the symptoms of malaria, such as a fever or flu-like illness, is beneficial to travelers. It enables them to realize that they need to seek medical attention without delay and to state that they have traveled to a malarious area. Worryingly, some migrant groups and their families do not access effective anti-malarial prophylaxis. Adult travelers born in Africa were reported to hold a belief that malaria was trivial or that they were protected from severe malaria. It is important to challenge and advise on misconceptions. Awareness of the risk is vital. Women may find the websites listed in box number 1 useful to learn about malaria for travelers and to reinforce the points already made to them. How should bites be prevented? Inform women about bite prevention measures, including skin repellents, knockdown mosquito sprays, insecticide-treated bed nets, clothing, and room protection. The Anopheline mosquito has different preferred biting times in different parts of the world, but making the assumption that the risk period is from dawn to dusk will suffice. In pregnancy, other mosquito-borne diseases such as dengue, which is caused by a daytime biting mosquito, should be prevented, so applying mosquito bite prevention measures 24 hours a day is advisable. Repellents. The evidence favors skin repellents containing 50% DEET or N-diethyl metatoluamide. Box number 1. Websites for pregnant or intending to become pregnant travelers to learn about malaria. Patient UK. This website supports the measures recommended by the Advisory Committee on Malaria Prevention in UK travelers and the Health Protection Agency and is available in a patient-friendly format with printouts. Health Protection Agency. This website provides general information, news, and guidelines. Centers for Disease Control and Prevention, USA. This website have various informative resources. The website also presents a realistic cautionary tale of a pregnant woman of 19 weeks on a trip from USA to Sierra Leone for a family crisis. There is also an interactive malaria map. Health Link British Columbia. This website gives good general advice on travel for pregnant women and is available in English, French, Chinese, Punjabi, Spanish, and Vietnamese. Malaria hotspots. Dynamic website with interactive malaria world map, malaria meets, frequently asked questions, and even a test of knowledge. It's not specific for pregnancy, but good general principles. Nobelprize.org. An interactive malaria games and a brief about malaria, not specific to pregnancy. In a sweaty environment, the effect of repellent is lowered and more frequent applications are required. There are few alternatives when 50% DEET is not tolerated, including PMD, IR 3535, Picardine 20%, and these are all less effective than DEET and require more frequent applications. Evidence demonstrates that not wearing repellent in a group where others do puts a person at more risk of being bitten. Knockdown mosquito sprays such as permethrin and pyrethroid sprays kill resting and flying mosquitoes. Pyrethroids will quickly kill mosquitoes and are the preferred ingredient in sprays, while permethrin will both repel and kill mosquitoes when used regularly in the same room. Insecticide-treated bed nets, long-lasting pyrethroid-impregnated bed nets offer significant protection. Long pyrethroid insecticide-treated bed nets without tears and well tucked in under mattresses or mats are estimated to offer a protective efficacy of 50%. Clothing that covers the body and forms a barrier from biting mosquitoes will reduce the risk of malaria. Room protection, electrically heated mats will kill mosquitoes in the room. Which drug can be recommended for malaria prevention in pregnancy? Inform women and their general practitioner of the risk and benefits of chemoprophylaxis versus the risk of malaria. Remind women that there is no malaria prophylaxis regimen that is 100% protective. The choice of drug and advice about chemoprophylaxis in pregnant women depends on the level of chloroquine-resistant Plasmodium falciparum and Plasmodium vivax malaria and the trimester of pregnancy. Chemoprophylaxis for malaria can be causal or suppressive. Causal prophylaxis is directed against liver escasant stage, which takes approximately 7 days to develop, so these drugs, for example, atovaquone proguanil or Malaron, need to be continued for 7 days after leaving a malarious area. Suppressive prophylaxis, such as mefloquine, is directed against red blood cell stages of the malaria parasite and so should be continued for 4 weeks after leaving a malarious area. Women should be warned that drugs purchased in endemic countries or over the internet may be cheaper, but they may be fake. Chemoprophylaxis for women planning a pregnancy. Women planning pregnancy and traveling to a destination where there is a risk of contracting malaria should be advised that there may be harmful consequences for the pregnancy. Prophylaxis is not 100% effective, and malaria is associated with increased risk of miscarriage. Women should be advised not to travel or to choose an alternative destination. If it's not possible to delay either the pregnancy or the travel plan, advice from a specialist with current experience of malaria should be sought. Chloroquine and proguanil are not efficacious in chloroquine-resistant areas and cannot be recommended because of this. There are very few chloroquine-sensitive areas remaining. To avoid completely any potential adverse drug effects from preconceptual and first trimester exposure, it is advisable to wait for complete excretion of the drug if it was taken for prophylaxis before becoming pregnant. Nevertheless, unplanned conception while taking malaria prophylaxis is not considered a reason to recommend termination of pregnancy owing to the low risk of teratogenicity. Chemoprophylaxis for pregnant or breastfeeding women. Mefloquine, 5 milligrams per kilograms once a week, is a recommended drug of choice for prophylaxis in the second and third trimesters for chloroquine-resistant areas. With very few areas in the world free from chloroquine resistance, mefloquine is essentially the only drug considered safe for prophylaxis in pregnant travelers. The majority of observational and clinical data, mostly second and third trimesters, suggest that the drug does not result in an increased risk of stillbirth or congenital malformation at prophylactic doses. Table number 3. Suggested waiting times before becoming pregnant with animal and human first trimester data on teratogenicity. The use of mefloquine in the first trimester may still be justified in areas of high risk of acquiring falciparum malaria. In the UK, this can be discussed with a specialist with current experience of managing malaria. There are strict contraindications to mefloquine, including current or previous history of depression, neuropsychiatric disorders, epilepsy, or hypersensitivity to quinine or mefloquine. Atovaquone and proguanil, or the Malaron, is potentially a good candidate for prophylaxis in the second and third trimesters, but it is not recommended owing to insufficient data on its safety in pregnancy. If travel to a chloroquine-resistant area is essential in pregnancy and mefloquine cannot be tolerated or is contraindicated, atovaquone and proguanil use can be considered in consultation with a specialist with current experience of managing malaria. Doxycycline and primaquine are contraindicated as chemoprophylaxis in pregnant women. Doxycycline has been reported to disturb bone growth of the fetus and to cause irreversible teeth coloration when given in the third trimester, and congenital cataract has been reported. Primaquine can cause hemolysis, particularly in G6PD deficiency. Fetal red blood cells are more sensitive to hemolysis, and the G6PD status of the fetus cannot be determined. While chloroquine and proguanil are safe, they are no longer efficacious in areas of chloroquine resistance and provide women with suboptimal prophylaxis if recommended. Recommendations for breastfeeding mothers are the same as for pregnancy. Atovaquone and proguanil may also be considered in consultation with an infectious diseases physician for a pregnant woman traveling to a mefloquine-resistant area. Emergency standby treatment in pregnancy. Written instructions should be given to a pregnant traveler regarding emergency standby malaria treatment in the event of suspected malaria without access to medical care. Suspected malaria is a medical emergency, and women should seek diagnosis and treatment at a health facility at the earliest opportunity. Early diagnosis and standby emergency treatment have been promoted in the event of remote travel without access to medical care within 24 hours of symptoms. Owing to reports of the misuse of standby treatment and the importance that is given correctly, written instructions should be issued. Standby treatment should be started if malaria is suspected, flu-like illness, and temperature is 38 degrees Celsius or above. Medical treatment for a full medical evaluation and in the event that the fever has another cause must be sought at the earliest possibility. Antipyretics should be used for fever. The only recommended treatment in the UK for pregnant women is quinine, 300 mg tablets, 2 tablets 3 times a day for 7 days, and clindamycin, 150 mg capsules, 3 capsules 3 times a day for 5 to 7 days. If a dose is vomited within 30 minutes, the full dose should be repeated, and if the dose is vomited after 30 to 60 minutes, half the dose should be repeated. The treatment should be finished, and mefloquine should be commenced 1 week after the last treatment dose. Drugs that are highly efficacious and well tolerated are likely to be the best candidate drugs for standby emergency treatment. Quinine may be efficacious in most parts of the world, but it is not well tolerated. Coartem or Atavacon guanil or Malaron, if not used as prophylaxis, could be used as standby emergency treatment.